So welcome back, everyone. Thank you all for joining us for today's webinar, which is part of our series of webinars funded by the Australian Government Department of Health, Disability and Ageing. And it's the first in this series for 2026. And if you've joined us before, you'll know that what these webinars and webinar series are all about is how to apply evidence into practice, which is part of our comorbidity project. My name is Christina Morell. I'm an Associate Professor, Deputy Director of Treatment and Translation Research, and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use here at the University of Sydney, where I also lead this comorbidity project. And I'm joined by other members of our comorbidity project team today as we bring you this highly anticipated webinar, which I know we're all very excited about here, which is being presented by Dr. Natalie Mastrogiovanni. And if you're able to stick around today to the end, Professor Catherine Mills will be facilitating the discussion section. But before we get into that, I'd like to acknowledge and pay respects to the traditional owners of country on which we're meeting and recognise that we are joining from many traditional lands. The traditional owners of the lands that I'm currently on are the Gadigal peoples of the Eora Nation, and I'd also like to recognise their continuing connection to land, waters and skies, and acknowledge the same for traditional owners of the lands that you're all joining from, and pay respects to elders past, present and emerging, as well as any any Aboriginal and Torres Strait Islander people who are joining us today. I'd also like to recognise and acknowledge many people with lived and living experience of mental health conditions and substance use, as well as their families and carers, loved ones and chosen families, many of whom have been involved in this project and the development of our resources over so many years. You'll all know by now, whether you're joining us live or watching the recording, that you're in listen-only mode, so we can't see or hear you. So I'd like to draw your attention to the Q&A and chat buttons on your screen. If you have any questions for Natalie during the presentation today, please feel free to use the Q&A button. If you have comments or anything other than questions, please use the chat. This just helps us keep track of what questions we pass on to Natalie, or whether there are any other questions for support, requests for support or tech issues that we need to help out with, particularly when we have so many of you joining us online, which is fantastic. And we will be making the recording and handouts from today available on our website in the next couple of days or early next week. If you find Zoom chat distracting, you can have a play around with the settings on your end to disable what messages you see, and our team will also be putting that in the chat if you want to have a play around with it later. Before I introduce today's session properly, I'll just quickly mention that you can access our webinar library and also register for our next webinar at our website, and the link to do that is on screen, and we'll be putting that in the chat as well. If you have a couple of minutes at the end of the session today, please take a moment to let us know if you have any feedback or suggestions for future webinars that you'd like to see. Today's webinar, and in fact the last few that we've had, has been based on suggestions from you. So now it's my very great pleasure to introduce our presenter for today, Dr. Natalie Mastrogiovanni. Natalie is a research psychologist at the Matilda Centre and also works as a clinical psychologist in community mental health, seeing adults with complex mental health needs. Natalie generally works with clients who have complex trauma backgrounds, personality vulnerabilities, emotional dysregulation, and substance use. We've been really looking forward to having this session. And I know it's not just our team saying this, but we keep hearing that this is an area that a lot of people working in this space are wanting additional support in. So I will hand over to you to get started when you're ready.
So thank you all so much for joining me today. I'm really looking forward to chatting about dialectical behaviour therapy, also known as DBT. And I've implemented DBT over a few years now within community mental health settings. And I like DBT because I find it to be a really great model to work with clients presenting with complex needs, because it can feel very containing for the therapist and the client. I also like it because it can be pretty adaptable. You can have a traditional DBT program, which is quite structured. And on the other hand, you can take the skills of DBT and use it in general clinical practice. And I want to preface by saying there is just so much to DBT and it's beyond the scope to cover it all today. But really my main aim is to give you a bit of a taste test of what DBT is and how it can fit within substance use treatment. But before getting started, I would like to acknowledge the traditional owners of the land on which I'm presenting on today, the Gadigal peoples of the Eora Nation, and pay my respect to their elders past and present. I'd also like to acknowledge the traditional owners of the country on which you are joining us from. And I also acknowledge those with lived and living experience who are present here today. I would also like to acknowledge the role of lived experience in this topic. So today I'll be talking about what DBT actually is, how you see DBT in clinical settings, the evidence for it, the skills and concepts, and how it applies to substance use. And I want to flag that it is hard to talk about DBT applied to substance use without first understanding the model, which does leave limited time to cover every concept of DBT applied to substance use. But I have covered the main bits, and I've provided further readings and resources for you to look into. So starting with what DBT actually is, DBT was developed by Marsha Linehan, and the main goal of DBT is to support clients to build a life worth living. DBT stands for Dialectical Behaviour Therapy, and breaking this down, D stands for dialectical. So dialectics is a philosophy, it's a worldview which forms the basis of DBT. And a core tenet of dialectics, which DBT draws a lot on, is this idea that reality is comprised of many opposing forces, but both are true and exist at the same time. So for example, we've got up, down, day, night, good, bad, etc. And being non-dialectical means being stuck in black and white thinking and unable to find the middle ground. So it's either this way or it's that way. So for example, in this image at the top on the left here, I'm wondering what people see, and I'd invite you to pop it in the chat if you can. I actually can't see what you say, but just pop it in the chat. Let me know. Some of you might see a lady, and for some of you it might be an old lady, and others might see a young lady, and for some it might be both, right? If we're being non-dialectical, we might say it's only the old lady or it's only the young lady. It's actually both here. It's that optical illusion, right? So a goal we keep coming back to in DBT is finding the middle ground by accepting that both opposing forces can be true at the same time. So for example, it's both a young and old lady, both are true. And a dialectic we come to a lot in DBT is acceptance and change. This is where we acknowledge that a person is doing their best and they can do better. If we just stay with acceptance, so this idea that they're doing their best, there would be no change. However, if we focus purely on change, this idea that they can do better, we're not meeting a client where they're at. So DBT really unites these concepts of acceptance and change to get movement with clients. Then we've got the B, which stands for behaviour. DBT is focused on behavioural change, and we're not looking at what's a good behaviour or a bad behaviour, but what is most effective to meet the client's life worth living goals. So for example, the behaviour of yelling at a child to get them to do something at home versus yelling at a child because they're crossing the road and a car is coming, it's the same behaviour, but the effectiveness depends on the context. So yelling at them to get something done might cause conflict and doesn't actually meet your goal of getting things done. Therefore, it makes it ineffective. Versus yelling at them because a car is coming, that allows you to meet the goal of keeping them safe, which therefore makes it effective. So we want to understand what triggers ineffective behaviours, which includes like we call them problem behaviours, and replace them with more adaptive and effective behaviours. And clients that utilise DBT can present with a lot of ineffective behaviours. They can be in chaotic situations, and as a therapist, it can feel like it's hard to know what to tackle first because everything feels important and everything is. So you could feel like you're constantly putting out fires, like little spot fires, and not getting any movement, right? So this is why in DBT, it's very much focused on 3 targets of behaviour in this order. So firstly, life-threatening behaviours, so anything that puts the client's life at risk, for example, suicidality, self-harm. Secondly, therapy interfering behaviours, so for example, not showing up to sessions, showing up late, not doing home tasks. And then quality of life interfering behaviours. So some examples of this could be wanting to reduce conflict with a partner or other loved ones, shoplifting, anger outbursts, mood swings. And often these quality of life interfering behaviours is what brings the client to therapy and what the client wants to talk about the most. That's the client's priority. But it actually comes last in the hierarchy because first we need to focus on addressing any life-threatening behaviours like suicidality because we can't work on their quality of life goals if they're not here and if they're not safe, right? Then we need to address any therapy interfering behaviours because again, We can't help them meet their goals if they're not engaging in therapy. And then, only then, can we start to address the quality of life interfering behaviours. So this hierarchy really helps us to decide what to prioritise in treatment. It's not so much what skills to prioritise early on in treatment, rather it's what behaviours are they presenting with, and prioritise those behaviours based on the hierarchy. Then we discuss the skills which are relevant to each of these depending on what it is. Now, when it comes to deciding where substance use fits into this, substance use is considered a problem behaviour because it moves clients away from their goals. And where it fits on this hierarchy does depend on what it results in. It can be either one of these. So it would be conceptualised as a life-threatening behaviour if they engage in suicidal actions while on substances, if they're using substances in a risky or life-threatening way that can cause death, even if it's not intended. And in these cases, this is where it would be an absolute priority to focus on substance use. Then we've got therapy interfering. So this is where the substance use could be getting in the way of therapy. For example, they're not turning up to sessions due to substance use. They might be coming late, or they might be coming to sessions under the influence. And then where substances might be affecting their quality of life is, for example, if it's interfering with their work, related to anger outbursts, no motivation, maybe spending too much money on substances. And we know that, therapy interfering behaviours in AOD settings is very common. And sometimes it feels like there's just too much going on and we want to pick our battles and get buy-in and build rapport. So part of that might be letting some therapy interfering behaviours slide. But unless there's any life-threatening behaviours, therapy interfering behaviours really is the next treatment priority, at least according to DBT. It really has to be the focus. And what this can look like is naming it from the start, using a butterfly metaphor. So Linehan talks about clients who use substances kind of like butterflies. So they might fly frequently in and out of the therapist's hands, departing just at the moment we believe they've landed for good. And typically, DBT clinicians, they can be the sole reinforcement for their clients in terms of warmth, encouragement, praise. But with clients who use substances, it can feel like you sort of have to compete with substances because they simply offer more powerful, immediate changes in emotions than therapists can early on. So this is discussed from the outset and used as a springboard to discuss the likelihood that the client might fall out of contact with the therapist, and then we plan ahead for that. So that could look like written consents to talk to social networks to get back in touch with clients, adapting session length to be shorter or longer as necessary, increasing contact with the client in the first few months. That could look like some check-in phone calls between appointments, some texts. And, for example, I've come across clients that might have forgotten about and rejected when therapists go on leave. So we made a plan for a team member to send a text while on leave so they know we're thinking about them. And this is particularly relevant with substance use, people that use substances, because they might be more likely to disengage. And I also like to ask, what worked and what didn't in prior therapies, what led to them disengaging, so we can be aware of it from the start. And then after that initial setup, if these therapy interfering behaviours come up, we can come up through the course of therapy. We can use a chain analysis, which I'll speak about later on, but it's essentially a tool to see what led to that therapy interfering behaviour, which then allows us to suggest which skills they can use to prevent it from happening again. And then we've got the T, so the therapy part. So DBT technically falls under the umbrella of being a type of cognitive behaviour therapy. And I would say that DBT is more focused on dealing with the emotion directly, whereas CBT focuses on changing cognitions and changing behaviour to influence emotions indirectly. And some parts about the therapy component is that we sort of see that the kindest thing we can do for a client in DBT is to push them towards their life worth living goals, even when it feels uncomfortable. And to do this, it involves implementing boundaries, including miss-session rules. So, for example, if they miss 3 sessions within a treatment block, they need to step down, or they might be out of the program. And this varies depending on the setting you're in. And there can be a misperception that it's quite punitive. However, in reality, a lot of the clients that utilize DBT haven't had safe and reliable caregivers. So implementing boundaries can be very containing. It introduces predictability and it keeps people on track, especially when their lives are very chaotic and it never feels like the right time for therapy because there's just all this other stuff coming up. And if the treatment is too flexible, it can feel all over the place, right? So if it is the case that they can't make, they can't make those 3 sessions or they miss those 3 sessions because things keep popping up, we talk about it with them as like, it just might not be the right time for DBT and what could they utilize for now and maybe come back to DBT in the future. The other thing about DBT that might make it a bit different from other therapies is that DBT considers the relationship between a therapist and a client to be a real relationship between equals. So strategic self-disclosures from the therapist are more common compared to other types of therapies. So how you would see DBT in clinical settings, these are the most common ways. Option 1 is a comprehensive DBT program. This often starts with a pre-treatment. So a pre-treatment is kind of like an extended assessment to really make sure DBT is right for them, orient the client to DBT principles and structure, really understand areas of dysregulation and patterns, introduce that hierarchy of target behaviours, and assess readiness for group by looking out for any therapy interfering behaviours that might affect their ability to engage. So, for example, if they're repetitively not turning up to sessions. And we're really working on this in pre-treatment so they have the best chances of completing the program and engaging well. So after the pre-treatment, they officially enter the program, and that involves group sessions and individual sessions weekly. Group sessions go for about 2 hours, roughly, depends on your setting. They're very structured. They're all about learning different DBT skills each week, which I'll talk about later. And the clients are there to learn skills, so it feels quite didactic. And the reason for this is it saves time in individual therapy. So the time in individual therapy can be spent actually applying the skills to their specific scenarios and also continue to build and maintain motivation. So it can be quite intensive for clients. It's about, say, 3 hours of therapy a week. We also offer, as part of a comprehensive program, phone coaching. This is where clients can call the therapist at agreed hours if they're about to engage in a problem behaviour and need support to use the skills. The comprehensive program also includes a DBT consult where everyone involved in the program, so group facilitators, individual DBT therapists, get together and seek supervision of our clients. It's kind of like a therapy for therapists. Then we've got option 2, which is where some services might just offer DBT skills group and they're just teaching the skills. It might require the client to see a private psychologist or another psychologist in another setting to monitor and manage risk. And research does support skills group as a standalone treatment, which I'll get to in a second. And then option 3 is, I believe, relevant to one of the questions that came through earlier around how can DBT be adapted when you don't have capacity to deliver the full program. And this is where you might choose to incorporate the DBT skills into a treatment plan in whatever setting you're in. And this is different to those individual sessions in the comprehensive program, which are quite structured. Instead, in this third option, this is where you incorporate the skills into the work you're doing when they're indicated. So in terms of the evidence, DBT was originally developed with the goal of reducing life-threatening behaviours in adult women struggling with emotion dysregulation, particularly in the context of BPD. And early RCTs, as well as more recent reviews and meta-analyses, consistently show that DBT leads to decreases in life-threatening behaviours, including self-harm, reduced suicide attempts, hospitalisations, and in BPD severity, and is now considered the gold standard treatment for BPD. That research was very much based on implementing the comprehensive DBT program, but the skills group has been found to be a critical mechanism of change in the DBT model. So research has indicated that skills-only training is effective as a standalone intervention for BPD. It's also considered a transdiagnostic treatment for common mental health disorders since skills groups have been shown to be effective at overall symptom reduction and improving emotion regulation in depression, anxiety, binge eating, and bulimia. DBT has been specifically adapted for adolescents, eating disorders, PTSD, and substance use. And there's also a type of DBT called radically open DBT. It's a type of DBT for disorders characterized by over control, including anorexia, obsessive compulsive personality disorder, whereas original DBT is more for under control of emotions, so that emotion dysregulation, whereas RODBT is for that over-regulation of emotions. So in summary, while DBT was originally developed for BPD and remains the gold standard treatment for BPD, it primarily targets the transdiagnostic feature of emotion dysregulation, which is likely what makes it so effective across a number of disorders, since emotion dysregulation is a feature of many disorders. So the DBT adaptation for substance use is basically the same DBT framework, but a key difference is that it provides additional skills to facilitate the treatment of substance use and addiction more broadly. And I'll talk about these skills later on. And those skills do share commonalities with cognitive behaviour relapse prevention, motivational interviewing, and the 12-step based approaches. This adaptation has been designed for the treatment of concurrent BPD and substance use problems. So it has been primarily tested in individuals with comorbid BPD and substance use, rather than as a treatment for substance use alone. And this is due to the comorbidity between substance use and BPD. There's research to show that approximately half of individuals with BPD have at least one concurrent substance use problem. So a lot of the evidence for the substance use adaptation is on populations with substance use and BPD, with limited evidence in individuals with a primary substance use diagnosis. It doesn't mean it's not effective for them, it just hasn't been tested as much. If you did want to consider DBT as a treatment for substance use alone, it would be about considering the extent to which emotion dysregulation plays a role in the individual's continued use of drugs. Then it would be a good fit for people who use substances to cope with difficult emotions. So the evidence we do have for DBT, the DBT substance use adaptation, overall shows that it is promising with reductions in substance use. But again, as I've alluded to, these samples are limited. They often include individuals with BPD and women only, and it sort of lacks rigorous tests with active comparison control conditions, including other evidence-based treatments. In saying that, this evidence is really centered around those structured DBT programs. It's still useful to incorporate the DBT skills into standard clinical care based on the formulation approach. So what are these skills and concepts of DBT? Before we get into the skills, it's really important to understand how DBT formulates and conceptualizes emotion dysregulation. And this I found to be very validating to explore with clients. So the biosocial theory was proposed by Linehan to explain the etiology of BPD, but it really applies to the transdiagnostic mechanism of emotion dysregulation more broadly. So the bio component of this, it's this idea that, humans are all the same, but we vary biologically. We have different eye color, different hair color, etc. And our biology reacts differently to the world. So, for example, gut reactions to foods we can tolerate differs. How our skin reacts to the sun differs. And that's the same with emotional sensitivity. Some people just naturally have a high emotional sensitivity. And what that means is they're more attuned to certain situations in the environment that trigger an emotional response that might not be triggered in others. So they notice emotional content more, and there's the potential to be triggered more often. They might also experience emotions more intensely. So the emotion goes higher, like a 0 to 100 effect, and there's a slow return back to baseline. And as there's that return to baseline, there's other things that come up, other triggers. So they keep kind of spiking up. And so it's really hard to come back down. But this alone is not enough to cause emotion dysregulation. It's when it's combined with the social elements. And specifically, it's when the emotional sensitivity doesn't fit the environment. There's a mismatch between environment and biology. In other words, an invalidating environment can influence emotion dysregulation. And it's about the transaction between the environment and the client. So, for example, you might have a caregiver, that's the environment part, and a child. The child shows an emotion, and the caregiver responds with what they know best, maybe based on what worked for their other kids, for example. So they might say, oh, get over it, it's not a big deal, you'll be fine. But the child has a different biology. They've got that emotional sensitivity, and so they keep emitting emotion. And then the caregiver escalates, and the child then dampens the emotion. They're learning that it's better not to communicate my emotions because I get in trouble. I'll just keep it to myself. Or, for example, you could have, say, a withdrawn caregiver for whatever reason, not meeting the child's needs. And the only time the child can get their needs met is when they escalate. And that's can be the only time the caregiver kind of gives them what they need. So this translates to big displays of emotions to elicit care. And this can be something that underpins threats to suicide, for example, because that's what they learned, that's what was reinforced. For example, I have had clients in the past telling me that the only time they thought caregivers noticed or paid attention was when they saw self-harm marks, for example. And this model resonates really well with BPD because you don't necessarily need to have trauma to have BPD. It's just a mismatch of the environment. And I really like the metaphor, the idea of a tulip in a rose garden. There's nothing wrong with tulips or roses, but the tulip just needs different care to roses in order to thrive. This also means that you can have really well-intentioned caregivers that just couldn't attune to the emotional sensitivity of the child. Caregivers that might, make their child laugh so they don't feel sad because they hate seeing their child sad, can be really well-intentioned, but for some, it can create emotional dysregulation because they're not taught how to sit with uncomfortable emotions, and therefore they might learn to avoid uncomfortable emotions via substances or other maladaptive coping behaviours in the picture. So in terms of the skills themselves, DBT skills consist of 4 modules, and the skills groups run on each of these modules. So we've got distress tolerance, interpersonal effectiveness, emotion regulation, and mindfulness. There's often, say, 10 weeks on each module. And for some programs, instead of mindfulness as its own module, it's at the start of every skills group. So they essentially get mindfulness 3 times. So mindfulness is at the crux of all DBT skills because we can't use a skill if firstly we're not aware of the external world. So what's the situation causing distress, and our internal world. So what's going on for us? What am I thinking? What am I feeling? What's coming up for me? And only then can we choose the most appropriate skill for any given situation. And an important part of mindfulness skills is mind states. So DBT would say we're often acting from emotion mind or rational mind, reasonable mind, robot mind. It's got a few different names. Both have pros and cons. So emotion mind allows us to feel more creative, connected to others, those pleasant emotions. But if we're only in emotion mind, we can't think clearly, things can feel chaotic, maybe those longer term goals aren't front of mind. However, rational mind is all about facts and logic and reason, and that's really good for making important decisions. However, if we were only in rational mind, then we can't necessarily enjoy life, we can't experience those pleasant emotions. So we want to find a middle ground and achieve both. And that's where we have our wise mind. Wise mind is the perfect synthesis of both emotion mind and rational mind. It's a dialectic in and of itself because both these mind states feel so opposite, but we're bringing them together. So I'll share a personal example to illustrate wise mind, which is what we do in DBT, strategic self-disclosures. So I saw these kittens up for adoption recently, and I was fully in my emotion mind. I was so excited, felt this love. I was so drawn to them and so ready to act impulsively. But my partner helped me to connect to my rational mind, which is, we don't have the space right now. He's going to look after them while we're away on holidays. And both are true, right? So my wise mind, really having to connect to my wise mind might be something like getting these kittens in a couple of months' time when we move places and after we've gone away, which is something that, honors both these mind states. And the other part of mindfulness skills is what and how skills. So what skills is what we do when we're practicing mindfulness, and how skills is how we do it, how we do the what skills. So when we're practicing mindfulness, we want to observe, describe, and participate fully in the moment, observing what's going on around us, what's going on inside of us, describing that for what it is factually, and participating fully in the moment. Then we've got our how skills. So we're doing that non-judgmentally, one mindfully, so one thing at a time, and effectively. So we're doing what works. Then we've got our distress tolerance skills. And I find these set of skills most helpful with substance use because they are essentially an alternative to acting on a problem behaviour. I also think they're relatively straightforward and practical strategies that can be readily implemented into practice. So distress tolerance skills have two goals. The first goal is all about surviving a crisis without making things worse. So clients often find themselves in what we call unrelenting crises. For example, in response to a crisis, clients can engage in problematic behaviours to cope because that's what they've learned. That could be something like substance use, which then compounds the original crisis. Then the crisis mounts, they engage in more problematic behaviours, further prolonging the pain and distress. So a real-world example of this could be, say, an argument with a partner. The person might drink to shut off from those uncomfortable emotions. They then say hurtful things while intoxicated. The partner leaves. There's even more painful emotions, more drinking to cope, might start to miss work frequently due to hangovers, results in a warning, more uncomfortable emotions, more drinking, fired, can't pay rent, etc. So this could be an example of crises just compounding and compounding. So our distress tolerance skills are all about getting through a crisis without making things worse. And a key foundation of this set of skills is to stop, the stop skill. This skill inhibits impulsivity. So stop is an acronym. The S stands for simply just stopping. T is take a step back. So removing yourself from the situation. O is observe. So what am I feeling? What am I thinking? What are my urges? What is the situation? And P is proceeding mindfully. So proceeding mindfully is about clients doing something that moves them closer to their goals. And this can often mean layering on another DBT skill, especially when distress is still high. So for example, the TIP skill is a really common one. It stands for temperature, intense exercise, paced breathing, and paired muscle relaxation. And a lot of people may have heard about the temperature skill, but I found it can be kind of varied in the rationale and how it's applied. In this case here, temperature, the idea here is that when we're in a crisis, we're in that fight or flight response and the sympathetic nervous system is activated. That motivates action, but it's really hard to think clearly and we can be very much in emotion mind. So what we need to do is activate the parasympathetic nervous system, the part of our body responsible for rest and relaxation. And the way we can do that is by using temperature, which activates the mammalian dive reflex. And this slows down the heart rate, shuts off non-essential body resources, and induces a sense of calm, which then reduces emotional intensity and creates a gap between urge and action. So the way we can do this is by getting an ice pack or something from the freezer, placing it over our eyes, bending over and holding your breath for approximately 30 seconds. Now, this is different to, say, holding ice, for example, to stimulate sort of a pain response or creating strong sensations as an alternative to problem behaviours. That's actually part of the distract skills. We call it S for sensations. And that's particularly relevant if the function of deliberate self-harm is to feel physical pain. So that can be the difference. We've also got our pros and cons, distraction, so ways that they can distract away from the emotional pain of the crisis, self-soothing through the senses, and improving the moment. So these skills are essentially serving or supporting the client to tolerate the distress and survive the crisis without needing those other problem behaviours to cope. And then the second goal of distress tolerance is skills for accepting life as it is in the moment. And a core skill of this is radical acceptance. This is one of the most challenging skills I find to talk about in DBT because it's quite confronting. And yeah, it's an actual very long process. It can take a lot of time to really utilize radical acceptance. But it's this idea that So the acceptance piece here is accepting reality for what it is, even if we don't like it, even if it's painful. The radical part is being radical about it. We're accepting with our mind, body, and spirit. And we need to do this because pain is a part of life. We can't avoid it. It's a certainty. And an example of this is like a very kind of crude example would be, for example, going on a tropical holiday and it's raining, right? So then we might say, this sucks, I can't believe it. I'm not going to enjoy myself. I wish it wasn't that way. Why me? It isn't fair. I'm not going to enjoy myself now. And what we're doing is we've got pain, but we're adding suffering to the pain. The pain, the other part of this diagram here, pain with acceptance, is this idea that it's raining, this sucks. It is what it is. The acceptance. And this is because the pain at the present moment is painful enough without adding on layers of suffering. But you can see how hard this can be for, say, traumas and that kind of thing. So it's an ongoing process. Then we've got our emotion regulation skills. And the first goal of emotion regulation is to understand emotions. And as discussed in the biosocial model, a lot of clients have negative perceptions about emotions due to the messages they received growing up. So we talk about the purpose of emotions, which is essentially psychoeducation. We talk about how emotions motivate us, they communicate to ourselves and to others. We also talk about barriers to emotion regulation. So this can look like challenging emotion myths and considering other barriers that might make it hard to regulate. So, for example, the biology of emotional sensitivity, skills deficit, like not knowing what to do when you have an emotion. And then we've got the function of emotion. So every emotion has a function. For example, fear, the function of fear is to respond to a threat. For anger, it's about approaching and dealing with injustices or when an important goal is being blocked. So the second goal of emotion regulation is to decrease emotional suffering. And the baseline kind of skill here is checking the facts, sort of like cognitive restructuring. It's where we encourage the client to consider what emotion they're noticing and a series of questions to understand if the emotion fits the facts based on the function of that emotion and based on the facts of the situation. We're also checking not just if the emotion fits the facts, but if the intensity and duration of the emotion fits the facts. So, for example, say the situation was someone cut me off in traffic, I might experience anger. That fits the facts because an important goal is being blocked. I want to get home. But what might not fit the facts is how long the anger lasts and how strong it is. So, for example, if I swore at them, if I yelled at them, or if the anger is sticking around, if it's all I could talk about and think about. So that's when we might do opposite action. Opposite action is when emotions don't fit the facts in terms of their intensity and duration, as well as the emotion itself, or when acting on the emotions isn't effective. So that, in other words, it's not aligned with our goals. So even though my anger might have fit the facts, the intensity and duration didn't. So I have to do the complete and total opposite of what I feel like doing. So it might be slowing down, smiling, relaxing my face. That's because it's more effective for how I want to live my life worth living goals. And this is also based on the idea that a lot of effective psychological treatments we have are essentially opposite action. For anxiety, the urge with fear is to avoid. So exposure is to approach. With depression, sadness, the urge is to withdraw. The treatment is behavioral activation, again, approach. So it's a really helpful way, like these sort of skills, to validate whatever emotions the client is experiencing, because often they do fit the facts, to be honest, but the way we act on that emotion can cause the problems. So that's where we want to be more effective. And then sometimes we've got to use problem solving, and that's where emotions fit the facts. So, for example, I'm feeling anxious because I don't have enough money to pay rent. That certainly fits the facts because there's a threat to yourself and your well-being. So we need to problem solve. We need to change the facts as much as possible. So in other words, what are all our options? What are the pros and cons of each? And then implement a preferred option. And then the final part of the emotion regulation skills is reducing vulnerability to emotional mind. And the goal of these skills is to be, the more we do them, the less vulnerable we are to strong emotional responses. So if a trigger was to happen, we won't have as much of a emotional response. And so the ABC skills, that's again an acronym. A stands for accumulate pleasant experiences in line with our values, doing things that make us feel nice. B, building mastery, doing things that give us that sense of achievement and competency. And C is coping ahead with emotional situations. So that's forecasting a trigger that might happen and planning how we will cope. Then we've got the please skills, which is all about taking care of your mind by taking care of your body. This is like taking care of physical illness, eating well, avoiding mood-altering substances. So here, substances can be seen as a vulnerability factor where they make the person more vulnerable to experiencing big emotions. Also sleep and exercise. And then finally, we've got our interpersonal effectiveness skills. So with our IE skills, we're deciding what your goals are depending on the nature of the situation and the nature of the interpersonal relationship. So the goal might be needing to get your needs met in a relationship, and that's when we use DMN. It could be getting or keeping a good relationship, and that's when we use give. And it could be keeping or improving self-respect, and that's when we use fast. And ideally, we want to maintain all of these in a given interaction, but one might take priority over the other. And typically, clients might stray towards only prioritizing the relationship at the expense of their own needs. So, for example, clients have described the feeling of feeling like a doormat in relationships, feeling really passive, or only prioritizing their self-respect. That could look like aggressive behaviors, right? So we want to find the middle ground. We want to try and be assertive and balance both needs at the same time. And the way we can do that is through DMN. And this gives clients a template of how they can either ask for something or say no to something in a way that considers both their needs and the other person's needs. So putting this all together, this curve represents the rise and fall of emotions. Core mindfulness is something we want to be practicing at all times, ideally. But when emotions are at that peak, that 10 out of 10 distress, they're really high, we need to be using the distress tolerance skills to get through the moment without making things worse, without letting emotions run the show and creating those unrelenting crises. So ideally, when we've used those DT skills, the emotions either staying up there with no unrelenting crisis or it's slowly coming down. And then when we get to that, say, 7 out of 10 point, good time to be doing our emotion regulation skills, because we're not just doing the distress tolerance skills and leaving it at that. We're actually coming back to, well, what's the emotion telling us? How do I process this? How do I make sense of it? And only once emotions are lower and we're closer to wise mind, out of that emotional mind, can we use our interpersonal effectiveness skills. It's really important to be regulated when we're using these skills. So that's how it works all together. And then I'll talk about DBT applied to substance use, which can really be done in one of two ways. Firstly, it could be done using the traditional DBT model. So I'm going to talk about how we would apply the strategies I just mentioned to substance use. And secondly, there is that specific DBT for substance use adaptation, which I mentioned. It is essentially traditional DBT with the addition of specific DBT skills for substance use. So I'll talk about that as well. So when it comes to DBT's stance on substance use, it's all about building a life without addictions. And DBT defines addiction as any repetitive behaviour that an individual is unable to stop, despite the negative consequences of the behaviour and the person's best efforts to stop. And the goal is to foster abstinence from addictive behaviours and prevent relapse. If relapse was to occur, then we engage in harm reduction. Determining the scope of abstinence involves targeting the primary drug. So that's the substance that's causing the most significant problems for the clients. And also targeting other drugs that appear to reliably precipitate use of the primary drug of abuse. So for example, say a client, every time they drink alcohol, they go on to use cocaine and marijuana. So alcohol is also a treatment target. And the third goal is making sure treatment goals are attainable. So committing to abstinence for a lifetime is just not it's too much to think about when substance use is a real problem. So DBT would say committing to abstinence for a period of time that the client can commit to with 100% certainty that abstinence will be maintained. So this could be 1 day or a whole month or even 5 minutes. And if I'm honest, the third point for me slightly differs to the DBT stance. I like to work towards abstinence and meet the client where they're at by starting with really realistic, manageable goals that don't always involve abstinence. So, for example, if the client is using substances daily, it might be about reducing the amount they use each day or having days that they're substance use free and really being guided by them. So really being guided by any way they want to reduce rather than abstinence per se. And then if they stray from that goal we set, then I would consider that to be a lapse. And I find this to be very dialectical because I'm meeting them where they're at with their substance use goals and also keeping in mind, we're working towards abstinence because part of you is still leaving the door open and you'll always be vulnerable to it. So it's just balancing that. So when substance use is considered a problem behaviour, these are some strategies I generally think are pretty useful in the core DBT skill set. The observe and describe mindfulness skills, this is where we're observing when an urge comes up. What does that feel like? Describing the urge non-judgmentally. So for example, I'm having an urge about alcohol versus this is so bad. Why is this happening? When we're just describing it for what it is, non-judgmentally, we're detaching from the urge and we're noticing it without getting caught up in it. Then we've got the pros and cons. So this is something for a client to complete while in wise mind. And I can be very transparent with clients that often nothing will feel as good as the substances in the short term, but the cons are what capture the long-term consequences. So when they've filled out that pros and cons table, it's something they can refer to when the urge is happening, which is often where those long-term consequences are not front of mind. Then we've got the stop and tip skills. So for stop, that's where we're reducing impulsivity and therefore likelihood of acting on an urge to use substances. And then tip can be seen as a replacement for that problem behaviour because it helps clients tolerate the distress in a similar way that substances do. We've got the distract skills. So any way that the client can distract from the urge, whether it's doing activities, watching shows, that kind of thing. And this can be used in conjunction with delay. So for example, we call it like distract and delay. So if in 10 minutes I still feel like, oh, I need the substances, I'll have it, but I won't until then. And in the meantime, I'll distract myself. When the 10 minutes comes up, resetting it. Okay, I'm going to see if I can go another 10 minutes. If in another 10 minutes I feel like I need it, then I absolutely will. And then eventually the urge comes down. Self-soothe can be a really good one if the function of the substance is to relax, because self-soothe is a way to calm and soothe the body. We've got emotion regulation, cope ahead plan. So this is where we're planning ahead for a situation, like a high-risk situation where there will be substances involved, and we're planning ahead to prevent a lapse. And then if a lapse was to occur, how we get back on track. So thinking about it beforehand. For the interpersonal effectiveness skills, Dear Man is very useful for how strongly to ask for something or to say no to substances. It can also, it's used for people asking if they need support in any way in cutting down their substance use. So for example, say clients live with people where substances are really accessible in the home. They could be using the Dear Man skill to ask for substances to not be as accessible because they know that's a big thing that leads to their use. And then we've got Give, which is all about building new drug-free relationships. And knowing when to apply each of these skills is based on a chain analysis because that's where we see the function of the substance use. So for example, if we see a thought on the chain where a client says, oh, I just really needed to relax, then we would do self-soothe. if a client might say, the emotion was just too strong, it was just too much, I just couldn't cope, was so overwhelmed, then distress tolerance would be useful. And this is an example of a chain analysis taken from the DBT manual. The top box here is essentially what a chain analysis is. So we've got that dark grey circle, which is a problem behaviour, the problem behaviour we're analysing. And in this example, it's drinking too much and driving drunk. And for this problem behaviour, we want to look at the prompting event. So what was the trigger? The trigger was the sister calling from out of town, saying that she wasn't going to come visit the next week like she was supposed to. We also here consider vulnerability factors. So that's stuff that happened before the prompting event that makes us more vulnerable to experiencing those strong emotions when a prompting event occurs. For this client, it was her partner said he had to take a business trip sometime in the next month. Vulnerability factors might also include feeling unwell, feeling tired, that kind of thing. Oops. And then after the prompting event, we look at all the links in the chain that led to the problem behaviour and the consequences after. So the links on the chain consist of actions, body sensations, thoughts, events, feelings, everything step by step in between the problem behaviour and in between the prompting event and the problem behaviour. So on the left is the chain of events. We can see what led up to it. And on the right was what could have been done differently. So that fifth link there is, this attempt to bring arousal down with distract skills, but it didn't seem to work. So on the right-hand side, we include the corresponding skillful behaviour, which is where we might add on more distraction skills, or download a movie instead of just watching what's on TV, which isn't interesting and doesn't grab the attention. And then that sixth link on the left says here, I started feeling agitated and thought, I can't stand this. So that indicates the function of the substance use was this inability to tolerate that strong emotion. So therefore, that corresponding skillful behaviour is the tip skills to bring the emotion down. And then we also reflect on the consequences and how to prevent it from happening again and repairing any harm. So then we've got our specific DBT skills for substance use, which is included in the DBT manual, and they were developed in a series of studies treating individuals with drug dependence. These skills can be integrated into the core DBT skills when addiction is the crisis. So these are those skills I was mentioning before that were included as part of the substance use adaptation. So a big one is dialectical abstinence, and that's where we're balancing abstinence with the possibility of lapse and harm reduction. So if we just stuck with abstinence, it can feel very shameful and disappointing if there is a lapse, and therefore it's harder to get back on the wagon. However, if we purely stuck with harm reduction, they might be more likely to lapse. So this leads us to the dialectic of committing to abstinence and acknowledging that you might have a lapse and therefore a harm reduction plan so lapses don't turn into relapses. The dialectic is to go for abstinence as hard as you possibly can, and if there is a slip, minimising the harm. Then we've got our clear mind. It's kind of like wise mind. So DBT calls it addict mind. It's a state of mind when you're giving into an addiction, you're ruled by your addictions, there's urges, you're willing to do whatever is necessary to get the high. Then we've got clean mind or abstinent mind, where you're not engaged in the problem behaviour for a period of time, but you're oblivious to the dangers and temptations of relapsing. So you lower your guard and defences and you might test yourself. So for example, I've got this under control. I can go to that party with lots of reminders of my substance use, lots of triggers. Clear mind is the synthesis of the two. We're in that dialectical abstinence state where ideally you're abstinent while at the same time aware of the dangers of relapse and actively engage in behaviours to prevent lapse or relapse. Then we've got community reinforcement. It's this idea that the immediate reinforcement, the high or emotional relief that the addictive behaviour provides is stronger than the long-term consequences. And that's part of the reason the addiction is maintained. So we need to change the reinforcement pattern. We want to reinforce abstinence. So for example, spending time with people who don't share the same addiction, increasing pleasant activities that don't involve addiction, abstinence sampling, which is where you commit to a specific number of days of abstinence to sample what it would be like to live without the addictive behavior. Deprive and reinforce is where you deprive yourself of something important that you would work hard to get back, and then you give it back to yourself as a reward if you engage in abstinence. For example, coffee or a TV show. This is the last set of skills now, and then I'll wrap up. We've got burning bridges, which is where you're slamming the door shut to any temptation. Leaving the door open might look like keeping emergency weed in the house or contacts still on the phone for obtaining substances. The idea is to make a commitment to get rid of everything that makes addiction possible, listing them, getting rid of them, and listing and doing things that will interfere with the addiction. So, for example, if I tell this person, I know for sure they'll do everything in their power to stop me. So once I tell them, there's no going back. And we want to build new bridges. So creating, for example, non-addictive images and smells to think about when having an unwanted craving. We've got alternate rebellion. This is when addiction functions as rebellion. So finding other ways to satisfy that wish to rebel in non-destructive ways. I haven't seen this one come up a whole lot. It could be more relevant for a younger cohort. And then we've got adaptive denial. So this is where you convince yourself that you do not want to engage in the addictive behavior when an urge hits, and that the addictive behavior is simply not a possibility. So in terms of further readings and resources, the asterisk one here goes into a lot of detail about the DBT for substance use adaptation, which is what I would highly recommend that resource. And then we've got our references, and yeah, thank you so much.
Thanks so much, Nat. I really appreciate the detail that you were able to cover in that talk as well. And you can see too how DBT would be really appealing to the field because of the, that transdiagnostic approach that you mentioned. And also the alignment with approaches to substance use generally.
Exactly.
Like when you talked at the beginning about meeting where a person where they're at, having broader goals around, what recovery looks like in terms of building a life worth living, defined by each individual, and that may or may not involve abstinence, as you said. Right. And I think just noting some of the things around, noting the language, I guess, that is in the therapeutic manuals, which is something that we often find in language, particularly that comes out of US therapy manuals. Maybe that might be something that clinicians here might like to adapt in the way that they do it. Yeah.
And so I've certainly taken that approach. Yeah.
Yeah. Awesome. And we do have some questions that people have put into the Q&A, but noting that I don't think we're going to be able to answer them at this time. Would you mind, Nat, if we got you to write those responses out to some of those questions, and we can, or record answers to those questions, and we might be able to put that online for people to come back to?
Absolutely. Yeah, happy to.
That would be wonderful. And I'll just put up, I think there's a couple of slides that I'm supposed to go over at the end here, just for people to wrap up. Okay, which I think is visible now. Yes, just to let everybody know, you can find out more information about the guidelines in the webinar series and other resources on the website on the screen. And also just mentioning again, we have an online community of practice for professionals in Australia working with people with co-occurring conditions, which you'll also be talking about very soon in more detailed discussion around DBT skills and case study applications. And thank you to everyone who's joined us today as well. We've got our next webinar scheduled for the 22nd of April with Professor Lexine Stupinski about strategies for working with anxiety in people who are also using substances. So thank you again, Nat, very much appreciated, and looking forward to the case study discussion. Thank you, everyone.